We're going to talk a little bit about transfusion burden and symptom management living with MDS. I think that's a really salient topic because the majority of patients with MDS are going to be transfusion dependent at some point. These are my disclosures. I work a lot with pharmaceutical companies in order to develop clinical trials and to provide consultation on focus. So I'm a clinician predominantly, so I see patients and I do a lot of research, but all of my research is really patient-focused. So I think it's really important to start any talk about myelodysplastic syndrome thinking through a patient case. So from my perspective, and I guess from your perspective, being the patient, I think it's important for the doctor and the patient to be on the same page and aligned. So this is a patient of mine. At the time I first met him, he was 65 years old and he was previously healthy. He presented to his primary care doctor with a complaint of progressive shortness of breath with exertion, just couldn't get across the room. He was really short of breath. He was mildly obese, but otherwise had been fit. At the time of original presentation, his blood count was notable for normal white cell count and normal platelet count, but he was anemic with a hemoglobin of 10 grams and a hematocrit of 30%. At the time of initial evaluation, he had an enlarged size of his red cells. So enlargement of the red cell size is a common finding in people with myelodysplasia. His was 103 femtoliters, up to 98 is considered normal. And a red cell distribution width of 18, which means that the red cells were bigger and smaller than expected. So it speaks to quality control in terms of red cell production. A bone marrow biopsy and aspirate was performed and was diagnostic for myelodysplastic syndrome with ringed sideroblasts. We'll talk about that in a minute. He had a normal karyotype, so when his cells were grown in a dish and induced to divide, they were poisoned at the time of cell division. He had a normal cytogenetic characteristic, so 46XY for a man, but his mutational profile showed a mutation in the gene SF3B1, which is a characteristic feature in patients with low-risk disease. So in order, why is this not moving forward? I click here. Okay. In order to make a diagnosis of myelodysplastic syndrome, you must demonstrate persistent cytopenias that are relatively stable for a period of at least 3 months. And this means anemia with a hemoglobin less than 12 in women or less than 13 in men, mildly low ANC, less than 1,800, and platelet count less than 150. And you have to exclude other causes. So very frequently you'll see when you see a doctor that they might have checked nutrient levels, so B12 and folic acid. They might have checked copper levels. You have to exclude other potential causes, including viral infections, alcohol abuse, recent medications, autoimmune conditions, or hereditary bone marrow failure syndromes. There are people, especially presenting at younger age, who can have genetic syndromes that kind of look under the microscope like MDS. And you have to make sure they don't have something else like aplastic anemia or acute leukemia or something like that. And then a bone marrow is performed, and on the bone marrow, you have to show that at least 10% of the bone marrow cells show what we call dysplasia. And dysplasia means that the bone marrow cells don't look like they're supposed to for their degree of development. And this can be in any of the 3 lineages, erythroid, neutrophilic, or megakaryocytic, or that the patient might have ringed sideroblasts more than 15%, increased myeloblasts, and or an MDS-related karyotypic or molecular event. And that means when you do the cytogenetics, you see abnormalities that we see in patients with MDS very repeatedly, or you have a molecular event. At the bottom of the screen here, you can see pictures of MDS cells under the microscope. Most of these are bone marrow cells. And you can see here on the first picture, there are hypogranular neutrophils. So very normally, neutrophils will have a bunch of little tiny granules inside. Can you see my pointer or not?
Can you move it around? Yep, I can see it, perfect. But yep, I can see it.
Okay. These are hypogranular neutrophils. This is what we call a pelgeroid neutrophil, which is bilobe neutrophils. This is erythroid dyssynchrony in terms of development. These are micromegakaryocytes. One classical feature that's seen very commonly in patients with MDS with ringed sideroblasts or MDS with SF3B1 are these ringed sideroblasts. So this is an iron stain done on the marrow, and you can see these little purple dots which encircle the red blood cell nucleus. And this is a sign of ineffective red cell production or ineffective red cell development, and is a characteristic feature of patients with this lower risk MDS subtype. So over the years, myelodysplasia classifications have evolved pretty significantly. You can see here, looking back to the original description of myelodysplasia in 1982, there were really only 5 MDS subclassifications. These expanded pretty dramatically with the 2001 and 2008 classifications, and then condensed a little bit. And then in 2002, we had kind of competing classifications which were published. And this has created a lot of angst within the community, but really hasn't changed what we do for patients very much. These days, I'm part of a group that's been trying to unify the diagnosis for MDS using artificial intelligence and a really incredible database combining a US data set and a data set from Europe. And this allowed us to do artificial intelligence assessment on more than 7,000 patients. And using this approach, there were really 3 genetically defined MDS subgroups. MDS with biallelic inactivation of the TP53 gene, which is considered a very adverse prognostic finding. People with MDS with isolated deletion 5q, this is the so-called deletion 5q syndrome, which is responsive to lenalidomide. And then MDS with mutated SF3B1, like our patient Bobby. The rest of the patients are really defined based on morphology, that is to say, the pathologist looking under the microscope. And that's why it's super important to go to a center that sees a lot of MDS, because the quality of the pathologic evaluation determines whether you get a good diagnosis. And we divide patients based on the blast percentage greater than or less than 5%. So we have these 3 genetically defined entities, and then 2 entities defined on morphology and blast percentage. And using this huge algorithm with a ton of patients and using the best computer modeling we can do, what we showed is these 3 abnormalities really are very distinct and very well defined, and the rest are not. Morphologically defined MDS is extremely molecularly heterogeneous with very different cytogenetic and mutational profiles, and nothing goes together. And then we identified that there are mutational events that are always AML irrespective of the blast percentage. So people who have a mutation in NPM1, if you have a CBP alpha mutation or a core binding factor leukemia, these diseases are distinct and not MDS. And there's no consistent genomic basis for people who have increased blasts. And these people have quite a variable prognosis as well. So speaking about prognosis, we use large data sets of patients to try and predict, when I have somebody sitting in front of me in the chair, how long is this person going to survive? And you can see that in the original classification schemes, bone marrow blast percentage and low blood counts were really the defining entities. And over time, we've added additional things and taken some things away. And fundamentally, over the last few years, bone marrow blasts, the degree of low blood counts, the cytogenetics, and the molecular features of disease are really the best way that we define prognosis. And if you take a patient sitting in front of me today, I use the IPSS-M scoring system to define patients in terms of risk for development of acute myeloid leukemia and prediction of overall survival. Okay. In general, when you compare the old scoring systems, the IPSS and the IPSSR, IPSS published in the late 90s and IPSSR published in 2012 to the IPSSM published in 2023, all of these later classification schemas using cytogenetics and molecular features effectively upstage patients in the majority of cases. And what that means is that we're getting a better sense of which people are less likely to do well or to more likely to have an adverse outcome, more likely to progress to acute leukemia. And that's what these additional molecular and cytogenetic features allow us to do more effectively. So in MDS, the treatment goals depend on the underlying prognosis of the disease. If I have a patient with lower risk MDS, my goals are to improve that person's survival, to decrease the likelihood that they'll transform to leukemia, to improve their blood counts and improve quality of life. If I have a patient who's got a high-risk disease that's likely to do them in a relatively short period of time, then my goal is to provide some form of therapy that changes the natural history of the disease and maybe offer them cure. And then, and so we kind of arbitrarily divide patients into lower and higher risk disease. And then our lower risk patients, we generally try to focus on improving quality of life and improving transfusion dependence. You can see here on the right box that we've had several agents approved for MDS in the recent past. For a long time, all we had were these hypomethylating agents and lenalidomide. And then in 2019, we saw the approval of luspatercept, and then in 2022, we saw expansion of this approval to all newly diagnosed anemic MDS patients with transfusion dependence. I think it was a really big step forward to have oral HMA available in 2020, and I was lucky enough to be part of that development program. In 2023, we have the first targeted therapy approved for MDS. That's ivosidenib. I'll touch on this a little bit in the future. And then imetelstat approved in 2024, now 2 years ago. You can see here a timeline for things that have changed over the course of the years. This is a gift from Dr. Caraway from the Cleveland Clinic. You can sort of place this in time as we look at new approvals compared with steps forward. For a long time, I think a lot of what we were doing was really defining the disease state more effectively. And now I think we're starting to see better drugs and new drugs approved. So I'm hoping that we'll see acceleration in this pipeline. So let's go back to our patient, Bobby. We rendered a diagnosis of low-risk MDS for him based on the presence of the mutated SF3B1 gene, the ringed sideroblasts, and the isolated anemia. And over the next 12 months, he became progressively more anemic with a hemoglobin dropping from 10 grams to 8 grams. We did testing for erythropoietin. We always check for EPO because that predicts the likelihood of response to various therapies, including erythropoietin stimulating agents like darbepoetin and erythropoietin, as well as to things like lenalidomide, as well as to things like luspatercept and lenalidomide. So this patient's EPO level was 100 international units per deciliter. He was B12, folic acid, copper replete. He had a normal TSH level, and his iron stores were high normal. So he started therapy with darbepoetin alpha, which is the type of erythropoietin stimulating agent that we generally start with in my practice. And we give this at the maximum dose of 300 milligrams once a week. The idea being that we start at the highest dose, and then if people don't need it as often, we can back off. And after 2 weeks, his hemoglobin had risen to 9.5 grams, and he was starting to feel better. So anemia is the most common symptom in patients with myelodysplasia. Up to 90% of people at the time of diagnosis will have anemia, and 50% of them will ultimately develop transfusion-dependent anemia. 54% of deaths in patients with MDS are actually non-leukemic deaths. And you can see here for men on the left and women on the right, the likelihood of death associated with the degree of anemia. So the lower your hemoglobin, the more likely you are to die from your MDS. And this has held true over a lot of different studies. This is from a European cohort. There was a study done using the European Leukemia Net group that looked at 1,683 patients with MDS and compared them to age and sex-matched European people without hematologic cancer or without any cancer. And what they showed here is that in areas of pain, discomfort, mobility, activity, anxiety, and self-care, patients with MDS generally performed less well, particularly in areas of mobility, activity, and anxiety, depression. Patients generally had worse symptoms, more problems compared to the EU norms. And these problems were moderate to severe, and these were worse in patients who were transfusion dependent. And in a multivariate analysis, the degree of the presence of transfusion dependence, a hemoglobin less than 10, these features were independently associated with worse quality of life for patients. So we know that patients with MDS have high iron levels. Many of them, especially people who have SF3B1 mutations, will actually have what we call iron loading, even if they are not transfusion dependent. And we know that patients who have higher iron levels, either due to transfusion dependence or spontaneous iron loading, tend to have worse cardiovascular outcomes. And so there was initially planned as a randomized phase 3 trial that actually was downgraded to a phase 2 trial. That means that they were able to enroll less patients, and because it took them such a long time, that looked at cardiovascular outcomes, that is to say admission to the hospital, new congestive failure, or death as a combined outcome in people using or not using, who are iron overloaded, using or not using iron chelation. And the question of this study was, could iron chelation improve survival? And you can see here that patients with MDS generally have increased iron. So this is a retrospective look at transferrin saturation on the left that shows cardiac death-free survival. And you can see people who have higher levels of iron had higher mortality here in the 80% here. And so this Telesto study was designed to ask the question, if you chelate these people, if you give people a drug that binds and removes iron from the system, can you change this? Can you make people survive better. And so this phase 2 study of desfarazerox versus placebo, again, originally designed as a randomized phase 3 trial, but amended because of really slow accrual to a phase 2 design, enrolled 225 patients with lower risk MDS to receive either desfarazerox or placebo, and they were randomized 2-to-1, so intervention versus placebo in a 2-to-1 fashion. Again, the composite endpoint of the study was worsening cardiac function, so lower ejection fraction or hospitalization for congestive heart failure. And in this study, you can see here desfarazerox versus placebo, the probability of occurrence of the composite cardiovascular event was somewhat higher in the placebo group versus the desfarazerox group with a borderline significant p-value. This study was disappointing because it didn't enroll as many patients as was originally planned. And so a lot of people have felt dissatisfied with this outcome. And so the decision of whether to chelate a patient with myelodysplasia, especially low-risk disease, who has MDS, remains a matter of some controversy, largely because people either believe in this study, believe in the impact of iron overload on MDS patients in terms of survival, or don't. I tend to be a believer because I think mechanistically, we know that if you take red blood cell precursors and you grow them in the presence of excessive iron, that they tend to be less effectively at doing their job. And if you take stem cells from patients with MDS who are iron overloaded versus not iron overloaded, those stem cells seem to produce red cell colonies more effectively in those who are not iron overloaded. That being said, many people cannot tolerate desfarazerox because of diarrhea or other symptoms. And so because we don't have prospective overall survival data to document that this improves outcome, I tend to not force my patients to keep on it, although I strongly believe that it does have potential for disease modification. So let's return to Bobby. He maintains his transfusion independence for a period of 18 months. And we try starting him on an iron chelator, but he has terrible diarrhea from this. And so he stops taking it and says that he will never take it again. And he unfortunately then develops progressively worsening anemia, now needing 2 to 4 units a month and feeling really terrible at a hemoglobin of 8. And he actually requests that we increase his hemoglobin goal somewhere higher, 9 or 10 if possible. His hemoglobin in the clinic on that day was 7.8 grams, and we repeat a bone marrow biopsy. And this is something that I always do for my patients at the time that I think that the therapy is failing them, just to prove to myself that there's not been a change in the disease state, that they're becoming higher risk disease. This biopsy shows, again, lower risk MDS with ring sideroblasts and the SF3B1 mutation with no new events. So if you review doctors and you ask them at what goal do you set transfusion threshold for your patient, and you provide different clinical scenarios, they will give you a different goal. And this is a survey that was done on doctors published back in 2017. So if you tell the doctor that the patient's 50 years old and asymptomatic without a cardiac history, most of the doctors will tell you that the transfusion threshold would be less than 7 grams. This is a European one, so they're listed in grams per liter, which are 10 times as high as in the United States. If you then tell the doctor that the patient has a symptomatic cardiac history, same age, they'll increase their goal, right? So instead of having a goal of less than 7 for transfusion, they'll increase, most of them will say less than 8 or less than 9. If the patient is 50 but had an MI 2 years ago and remains asymptomatic, then most of them will again make this goal a little higher. If they're 80 and asymptomatic but no cardiac disease, most of these people will say a hemoglobin goal of 8. Okay, so what this sort of says to you is that although theoretically transfusion goals are fixed, in point of fact, most doctors will move the bar depending on the clinical situation of the patient. Okay, and again, this is an Australian survey of doctors. So if you then go and ask patients, what do they want? This is a survey done by the group in Canada of 475 transfusion-dependent MDS patients. And in this study, a majority of the patients had a transfusion goal less than 8. So some of them less than 7, some of them 7.5, some of them 8. A minority of patients, 11%, less than 15%, actually had higher transfusion goals. And actually almost 50% of the US respondents had a hemoglobin threshold less than 7.5 grams. And 20% of the patients surveyed in this study did not know what their hemoglobin threshold was. Patients said that the symptoms which were having the greatest impact on their quality of life were fatigue, weakness, and dyspnea. And after a transfusion, patients mostly reported that they felt better 1 to 2 days after the transfusion, although a minority of patients said that it took more than 5 days for them to feel better. So if you compare the transfusion threshold for the patients that they were currently at with the transfusion threshold that they would prefer, actually a majority of patients asked for a higher transfusion threshold than they were, with 63% wanting the transfusion threshold to be 8.5 grams, and 20% of people actually wanting the threshold to be more like 10 grams of hemoglobin. So what this sort of says to you is that patients and doctors have quite a disconnect in terms of what they wanted. So that I said that without clicking, but you can see here. I didn't realize this is a built slide. Okay, so in order to understand this a little bit better, my friend Rena Buckstein, who's up in Canada, just across the border from me here in Buffalo, designed a prospective study called the Red Blood Cell Enhanced Study that was actually just published 2 years ago in Transfusion Medicine. And in this study, she randomized patients to a liberal transfusion goal, trying to keep the hemoglobin between 11 and 12 grams, versus a restrictive goal, somewhere less than 8 grams. And the endpoints were the achievement of 70% of the goal hemoglobin over the period of time that they were testing, quality of life endpoints, iron studies, and the safety of this approach, right? Because a lot of people say, okay, well, it's not safe because you're going to bring up the iron levels and you're going to have people get iron overloaded. Is there anything we can do? So in this, the mean pre-transfusion hemoglobin threshold, hemoglobin in these patients was 8.6 plus or minus 0.9 grams versus 9.9 plus or minus 0.9 milligrams per deciliter. And you can see here that the liberal transfusion goal patients had a higher hemoglobin than those who were getting the restrictive transfusion. Overall, in the liberal arm, patients got 5.6 extra red cells over 12 weeks. 5.6 extra CBCs over 12 weeks, 3.5 extra treatment visits, 5.3 more units of blood, and 5 fewer days between transfusions, 13 versus 19. And the ferritin increased pretty significantly, 926 versus 28 international units per liter. The symptoms were better in some patients. You can see your fatigue was significantly better. Dyspnea was somewhat better. Insomnia was better. Diarrhea was worse. Financial concerns were worse, not surprisingly. There was an improvement in global quality of life for some patients, but not everyone, right? In the restrictive versus liberal transfusion. This is physical functioning scores changing over time. Down means they were getting better. Up means they were getting worse. Okay, so although symptoms were better in some people, they weren't better in everyone. And so our general treatment algorithm, if you read the NCCN guidelines, it's kind of summarized here. So if you have a patient who presents with symptomatic anemia, if they have a deletion 5q syndrome, that is to say the presence of an isolated 5q mutation on the cytogenetic assessment without any high-risk mutations, that patient is usually going to be offered lenalidomide, okay? And then if they progress, they would be offered EPO if their EPO level is less than 500 or arguably less than 200, or luspatercept or imetelstat with limited evidence. If the EPO level, if they don't have a del5q, if the EPO level is less than 200 and they have an SF3B1 mutation or ring sideroblasts, luspatercept is arguably the first-line therapy here. If they don't have a mutation in SF3B1, ESAs or luspa are considered reasonable, and then if they progress, imetelstat. If you have a person with particularly high transfusion burden or a high serum EPO level, imetelstat, this new kid on the block, is probably your best bet in this group because that's where the imetelstat was studied. And then if the patient progresses or doesn't benefit from one of these things, you can try the others. And then I always want to mention clinical trial or chemotherapy with HMAs or bone marrow transplant consult is also reasonable in this population of people. So I don't rule out a transplant in patients with low risk MDS if they have failed all existing therapies. So I'm going to touch briefly on this drug, luspatercept, which is really becoming a very primary therapy for our patients with MDS. This drug was FDA approved based on a phase 3 study compared with erythropoietin alpha. The inclusion criteria included lower risk patients who either did or did not have ring sideroblasts. Actually, a majority of the patients on this study had ring sideroblasts. These were patients above the age of 18 with low blasts, and they had to be transfusion dependent for at least 2 units over 8 weeks, and they could not have received previously erythropoietin. They couldn't have a high white cell count, deletion 5q MDS, low neutrophils or platelets, or prior use of a disease-modifying therapy. And they were randomized 1-to-1 to receive luspatercept, starting at a low dose and then titrated up to the highest dose of luspatercept of 1.75 versus erythropoietin alpha. And they were stratified based on the need for transfusion, so how many transfusions they were getting, less than 4 per 8 weeks versus more than 4 per 8 weeks, their EPO level, and the presence of ring sideroblasts. And the endpoint for this study was transfusion independence for 12 weeks with a mean hemoglobin increase of 1.5 grams. I'll say parenthetically that one of the problems in MDS is that the endpoints of these studies are not all exactly the same. And so the period that we're looking at as the international working group, we recommend a period of 16-week transfusion independence. Historically, this IWG or the international working group recommended an 8-week transfusion independent threshold. We're trying to move to getting all the studies having the same endpoint, which helps us, and a mean hemoglobin increase of 1.5 grams. Okay, so in the NCCN now, based on these data, which were positive, for patients with low blasts and SF3B1, we prefer luspatercept, and imetelstat is considered. And the dosing, again, is you start at 1 milligram per kilo per week, and you escalate. If there's no transfusion after 6 weeks, you can escalate. If there's transfusion within the 6 weeks, you can escalate to 1.33, and then not transfusion free at 12 weeks, you can escalate to 1.75. And this study actually showed superiority of luspatercept compared with erythropoietin alpha across all of the different sub-analysis. So red cell transfusion independence for 12 weeks, for 24 weeks, and for hematologic improvement. And with long-term follow-up, again, superiority for the luspatercept over the erythropoietin alpha. And the group as a whole for greater than 12-week independence, greater than 1 year transfusion independence, actually 58% of luspatercept responders responded for more than a year, and greater than 1.5 year transfusion independence occurred in a smaller percentage of patients. So for some people, this can actually be great. One of the things that's kind of annoying about this is this need to dose escalate slowly. And so Dr. Zaidan presented last year the results from a study called the Maxilis study, which said, okay, in using erythrocyte stimulating agents, or ESAs, we actually give people the maximum dose and we dose de-escalate to try and get the maximum response as quickly as possible so that patients don't have to suffer through ineffective therapy. Could we do this with luspatercept as well? And so in this study called the Maxilis study, patients were started on the maximum dose of 1.75 milligrams per kilogram right off the bat, and then could be dose de-escalated if they responded too well. And so this is the data for that. The primary endpoint was red cell transfusion independence for 8 weeks with a concurrent increase in hemoglobin of 1 gram. Remember, in the past, it was 1.5 grams. But 73% of patients achieved this primary endpoint, with 70% of the population achieving transfusion independence for more than 12 weeks. It was higher in people with ring sideroblasts and higher in people with a low EPO level. Okay, so this is something we are routinely doing now. We're trying to start with the highest dose of luspatercept, and then if the drug is not going to work, we will get a sense of what's going on early, so we can offer patients a different therapy more quickly. So get in my laboratory, I have a mentor who always said, do the experiment that's going to cause your line of thought to fail as quickly as possible so that you stop going down the wrong path. And I think that's really important for patients as well. And so for my patient, despite an increased transfusion goal of 9 grams, he continued to really feel poorly. And we repeated his EPO level, which was 200 international units per deciliter, and his ferritin was 800. So we started therapy per the Maxilis study with luspatercept at the maximum dose, 1.75 mg per kilo every 3 weeks. Another drug that is actually very exciting and was approved about 2 years ago is this drug imetelstat, which you may have heard of. It's really a first-in-class inhibitor of an enzyme called telomerase. The idea here is that cancer cells are dividing more quickly and more frequently than healthy stem cells. And so telomerase is an enzyme that caps the chromosomes and allows the chromosomes to maintain their stability during replication. If you inhibit the activity of the telomerase enzyme, the capping pieces on the chromosomes erode. And so anything that's growing more quickly is more likely to develop mistakes. And therefore, the cancer cells are selectively thought to be killed by this inhibitory action compared with the healthy cells. And in the clinical trials, the early clinical trials and in vitro studies, the idea was that you would selectively kill the cancer cells and allow healthy stem cells to grow back with recovery of red cells, white cells, and platelets. And this is a drug that binds to the RNA template, which prevents the maintenance of the telomeres, and it's a competitive inhibitor. And it's given as an IV infusion every 4 to 6 weeks. So this study was examined in a randomized phase 3 clinical trial led by Uwe Platzbecker from Germany. And on the picture on the left, what you can see here is patients receiving imetelstat 2-to-1 versus placebo, randomized 2-to-1 to receive the active drug versus placebo, 47 patients receiving imetelstat and 9 receiving placebo. And they start therapy, and you can see here the really dramatic improvement in hemoglobin in patients who were started on treatment, okay? The median change in hemoglobin on this study, phase 3 study, was 3.5 grams versus 0.8 grams on the placebo arm. And the median hemoglobin peak in this study was 11.25 grams of hemoglobin versus 8.8 in the placebo arm. And so the patients achieved extended periods of red cell transfusion independence. You can see 40% of patients were transfusion independent for at least 8 weeks. More or less 30% were independent of transfusion for more than 16 weeks. And almost 30% of patients were independent for more than 24 weeks. And almost 20% of patients achieved a year of transfusion independence with marked decreases in the need for transfusions in this population. So this resulted in the FDA approval of imetelstat for patients with MDS. So we tried 9 weeks of luspatercept at the maximum dose for Bobby. And despite all this effort, he did not respond to therapy. And so we switched him to imetelstat. Imetelstat, remember, given as an infusion once every 4 weeks. So at week 4, after the first dose, we noticed that his blood counts had really tanked. He was neutropenic, his neutrophil count was 0.4, and he needed a platelet transfusion. His platelets were less than 10. We were pretty distressed about this, and we delayed his cycle 2. With that delay, we saw that his blood counts recovered, and now his hemoglobin was 11.5 grams and his platelets were 100. So you might initially think that these low blood counts, which he never had before, remember he's an MDS with ring sideroblast patient, and patients like that usually have normal platelets and normal white cells. But this patient, when treated with imetelstat, really dropped his counts and needed growth factor support. And that might be concerning. And actually, initially, when we had presentation of these data at the ASH meeting, everybody at the meeting was very worried. But what we found is that, in fact, patients who develop early low blood counts in the first 1 or 2 cycles of therapy are more likely to respond in terms of hemoglobin. And we think this is because, like lenalidomide, which selectively kills deletion 5q cells in the bone marrow, luspatercept is selectively killing the cancer clone, and it takes some time for the healthy stem cells to grow back. And so what you see here is the degree of 8-week transfusion independence, or the rate of transfusion independence for at least 8 weeks in people who drop their platelets by at least 50%, and people who drop either their platelets or their neutrophils by at least 50 or 75%. And you can see here that the rate of transfusion independence is significantly longer in those patients. And indeed, the rate of 24-week transfusion independence is significantly longer in those people who drop their blood counts in the early cycles of treatment. And so this is really an important marker of activity for the drug. And so one of the things I do for patients when I'm starting imetelstat is I warn them, goodness me, you're going to see low blood counts if it's working. Don't give up. And we use liberally growth factor support to improve the neutrophil count, and we transfuse people if we need to. Sometimes we use growth factor support for platelets to allow people to stay on medication. And most people need to be dose reduced on this drug and end up tolerating it pretty well. What I will say is that once you get started on the drug, if your baseline platelet count was 250, probably you'll end up with a baseline platelet count more like 100 or 150 because we do see decreases in the platelet count. So those are the two new FDA-approved drugs that are being used routinely for patients with MDS. We have another couple of targeted drugs that I want to touch base on, or I just want to touch on, because these are also used for low-risk patients, and they really represent a completely new arena in people with MDS. We never have had targeted therapies for MDS before. So ivosidenib is a selective inhibitor of IDH1, which in 2023 was FDA approved for patients who had previously failed a therapy for MDS, as long as they had a susceptible IDH1 mutation detected by an FDA-approved test. And what you can see here in the left panel is the hemoglobin over time and the bone marrow blast percentage in these patients over time. This was a study published in the New England Journal of Medicine by Courtney DiNardo from the MD Anderson Cancer Center. And you can see really dramatic improvement. There were very small numbers of patients on this study with MDS, but because these results were so dramatic, these drugs were FDA approved. And you can see here baseline transfusion independence after the baseline in almost 100% of patients achieving a response. And the overall response rate of almost 40% here. And this was a mixed bag of patients, most of whom actually had higher risk disease. There are studies that have been recently completed in France with this agent showing very dramatic responses in people with lower risk MDS, up to 60-70%, that seem to be very prolonged. Okay. The other drug that's another targeted therapy for MDS patients is the drug enasidenib, which is actually an inhibitor of IDH2. This drug was somewhat later to the market. It's been tested again by Dr. DiNardo in newly diagnosed higher risk MDS patients in combination with azacitidine and in previously treated MDS patients as a single agent. And what you can see here is overall response rates in the newly diagnosed setting of 75% with complete remissions in 26% of patients and overall survival of 26 months. Remember, this is a cohort of higher risk patients, really not lower risk patients. But we recently have, I should have guessed, put it in here, the IDEA and IDIOM studies, which were completed in Europe. We don't have the final publications from those studies using ivosidenib and enasidenib in newly diagnosed or relatively early lower risk population of patients with MDS, and showing overall response rate in lower risk patients with transfusion independence of more than 60%. And so I think these two targeted drugs in the right patient population can really be amazing. Overall survival is excellent. So I think the other thing that I really want to harp on is that if you achieve transfusion independence, you will, if for a patient with low risk disease, you are going to get better overall survival. On the left-hand panel here, you can see publication of combined data from the Medalist study looking at luspatercept versus placebo in patients with, luspatercept versus erythropoietin alpha in people responding. Luspatercept versus placebo in people responding versus not responding to the luspatercept. And what you can see here in kind of dark red is that people who responded had better overall survival, whether they got placebo or luspatercept, okay, compared with people who did not respond. And again, Dr. Santini looked at combined studies over various years using the drug lenalidomide, the targeted therapy that we use for people with del(5q) syndrome. And what you can see here is people whose hemoglobin improved and who achieved transfusion independence had markedly improved overall survival. This is with long follow-up up to 78 months, okay? And so this is really speaking to data that was again reiterated by a recent publication from Dr. Kamaragi from the Moffitt Cancer Center down in Florida, who looked at real-world data using US claims databases. And what he showed is that, again, no matter what, if you are transfusion independent with any therapy, first or second line, you're going to have better survival. So the name of the game here for patients with lower risk MDS is to prevent and treat to prevent transfusion dependence. Okay. And so just in summary, I think you probably are aware that people with MDS have poor quality of life compared to age and sex matched healthy people who don't have MDS. And a lot of this is driven by low hemoglobin. Iron overload is something we see in patients with MDS. Sometimes we actually even see it in people who are not requiring transfusion. And cardiovascular toxicity is a meaningful endpoint and impacts survival. Chelators might help with this. I actually recommend to my patients to be evaluated by cardiology when I see them with newly diagnosed MDS, because we know that people with clonal hematopoiesis or mutations in the blood have a higher risk of vascular disease. And so I recognize that this is the case, and I routinely now send my patients for evaluation by cardiology and potentially to get a stress test. And I also recommend that my patients initiate regular exercise after clearance by cardiology in order to maintain their physical plant, because the better your training level, the better you're going to be able to tolerate anemia and the less transfusion requirement you're going to have, because you're going to feel better. We know transfusion dependence is a serious burden and associated with shorter life expectancy. And so the name of the game should be decreasing the risk for transfusion dependence. Sometimes higher transfusion thresholds are worth it to help people feel better. We have new drugs that are somewhat active. Luspatercept and imetelstat will benefit almost 40 to 60% of patients. And we have old drugs that are also active. Lenalidomide for DIL5Q is actually really extraordinary. And these drugs can improve blood counts and lower transfusion needs, and when effective, are actually associated with better survival. And we have some targeted drugs now for patients with mutations in IDH1 or 2, which represent maybe 15 to 15% of patients with myelodysplasia. They offer significant activity and possibly extension of survival. And fundamentally, we know now that transfusion independence, no matter how you get there, really predicts better survival, and that should be the goal for our patients. I think that's the end of my slides here. I did 41 minutes, which I think is correct. Good on reasonable time, and I'm happy to take any questions at this time.
That was wonderful, Dr. Griffiths. So incredibly informative. So as Dr. Griffiths said, we do have a little bit of time for questions here. So we'll go ahead and hop in. If you have any questions, please feel free to drop those into the chat and we will address as many as we can. We've got about 5 minutes or so for questions. First question in here is asking, did the patients who wanted a higher transfusion threshold understand the risks of elevated iron levels?
So yeah, I mean, I think that was a clinical trial that was for which people were consented, and so all the risks versus benefits were provided to those patients.
Okay. And then next up, I have a question here that says, if I require frequent transfusions, will my body eventually start rejecting the donor blood? And how do you prevent or manage that?
So yes, red blood cell transfusion means that you are being exposed to other people's blood. And depending on your tissue type, the more transfusion you get, the less benefit you might receive, because you will become what we call alloimmunized. People make antibodies, and then this can cause it to be hard to find good matches for the blood, but it can also cause the benefit of the blood to be lessened. And so this is again a big problem we see in patients. In people who have genetic problems making red cells, we actually try to limit the number of donors that patients see. So I have patients who have genetic problems that result in a failure of hematopoiesis. There's a disease called Diamond-Blackfan anemia, where kids are identified when they're little. And for some of those patients, you can actually create a small pool of donors and specifically direct red cell transfusion to those people. Obviously, for people with MDS, that's a much harder ask, and it's much harder to get people to create a donor pool for somebody who's 80 than it is for somebody who's 5 or 1 year old, right? Just because of how people feel. So ideally, what I do is I say, okay, we're going to use single donor units and not pooled red cell units, because each single donor unit is from a single donor. In some cases, you can't be that picky, right? Because depending on where you are, you might not have blood bank access to single donor pheresis units. But that's one thing you can do. And we can chelate patients to decrease the burden or the problems from iron overload, which we talked about before. But certainly it is the case that the more transfusions people see, the more trouble you may have with getting well-typed units, with the duration for which those transfusions last, and for the bump that you get from the in terms of hemoglobin improvement.
Okay. And then next up I have, is enasidenib only effective for those with an IDH1 mutation?
So enasidenib is only effective for people who have an IDH2 mutation. Ivosidenib is for people with an IDH1 mutation.
Okay.
And those drugs are only effective if you have the mutation. And in those patients, they have pretty impressive activity. But you have to have the specific mutational event. Unfortunately, outside the context of IDH1 and IDH2 mutations, we do not yet have any other targeted therapies for people with MDS.
Okay. And then next up, and this one actually ties in really well with our survey that's about transfusion burden, which Dr. Griffiths was kind enough to help us design. But this individual is saying that spending hours in an infusion center is exhausting. Are there any ways to streamline the scheduling to improve their weekly quality of life?
I wish. You know, this is the pet peeve of everyone who does this, right? The lack of diffuse blood banks available within communities is a huge problem, because many people have to travel a long distance to get to a transfusion center. And then once you arrive, most blood banks will only keep a type and screen or type and cross good for a period of 3 days. And then after 3 days, you have to retest. Okay. And there's real reasons for that, and it's understandable. But but it really means that people have to come get a count check, and many people wait for that count check to show result, and then they have to wait for the blood bank to then type the blood. And depending on who you are and how many antibodies you have, that can take half an hour to 3 days, depending on what you got. And some people have to wait for HLA matched blood. I wish there was some way for us to organize for people to be able to stick themselves at home, or to check, at home, and see what the hemoglobin is. And if they're high enough to not need a transfusion, to just forego the appointment. And if they need a transfusion, I wish there was some way for us to do something remote where you could do a home blood draw and type in grass and only come in when the blood was ready. Unfortunately, that's sort of that's a dream right now. I've been working to try and get Roswell to increase availability of blood banking within our local within our local community affiliates and other places, but it's really hard because you need a blood banker to do that. You need the staff to do the typing, and that's a really specialized thing. So again, that's the worst part of it.
I think it is a tremendous burden. We recognize that, and that's part of the reason the survey was developed as it was to really capture that burden, to make it more well known. So everyone be on the lookout. The link for that survey will be included in our follow-up email. We have one final question in here, and then we are going to have to stop after that. But this individual is saying that their husband is a high-risk MDS patient. Why is this cancer so wild with so many variable symptoms? I feel no symptom is the same except for low hemoglobin or platelets. Can there be, or is there a cure outside of a bone marrow transplant?
So right now, we don't have anything that offers a curable outcome, a curable long-term survival, except allotransplant. It's the best therapy we have for people with MDS. It offers the only opportunity for cure. I think we're all hoping that we're going to be able to find something else. Unfortunately, we don't have anything better right now. We looked at, I'm part of a consortium of doctors internationally contributing to something called the Validate database, which is a database of patient information for people receiving HMA-based therapies for myeloid malignancy, mostly MDS. And what we showed, this paper I think is under review right now, but was published previously at ASH, is that patients with MDS who undergo allogeneic stem cell transplant, the driver for long-term survival is actually unrelated to whether or not they respond to treatment. So if you have high-risk MDS at the time of your original diagnosis, whether you achieve a response to hypomethylating therapy and then go to transplant, whether you go up front for transplant, the driver of outcome is the baseline IPSSM, right? The baseline prognostic score. And it doesn't matter whether you respond or don't respond to therapy. It's really the baseline IPSSM and getting to transplant that matters. People do better if they can get to transplant with high risk MDS, right? And so I think within our community, we're all of us trying to struggle with how to get people to transplant effectively and improve the toxicity of the transplant so that more people can gain access. Right now, at least until recently, transplant has been reserved for people who had good organ function, so excellent kidney function, excellent performance status. Age, older people were excluded. We're pressing that barrier. We do bone marrow stem cell transplant to people up to the age of 80, sometimes up to the age of 85. We've recently changed some of the conditioning. We now have an opportunity to do transplants in people with less good renal function. And so one of the things that I've been part of is to really drive that process to offer transplant to a larger number of patients, particularly those with high risk MDS. I think for people with lower risk MDS, the benefit of transplant is less clear. But I think if you've had all the therapies that are currently FDA approved and you're no longer benefiting and you're transfusion dependent, it's pretty clear that long-term survival is pretty poor, right? The more transfusions you require, the less likely you are to do well, and the more you are likely to have an adverse outcome and a shorter survival. And so for people who despite all therapies, remain transfusion dependent with low risk disease, even if they don't have a high blast percentage, I am now routinely referring patients like that for allogeneic stem cell transplant and consideration of that therapy.
Okay. And that is going to take us to the end of our time here. Thank you again, Dr. Griffiths. This was truly so informative, and just all of the work that you do for the MDS community is incredible. So we're honored to have you with us today.
Thank you so much for your time and attention. I really appreciate it. I hope this was informative and valuable.
And as we're getting ready to hop off here, I did want to let everyone know about some upcoming educational events that may be of interest to you. So on Tuesday, July 7th at 1 p.m. Eastern, we have our bi-monthly cancer financial Q&A, expert answers to your treatment costs and support questions. So a really good space to ask those financial questions. Living with cancer is expensive, and we recognize that. So we try to offer ways to help support or get you answers to your questions. So if that would be of interest, highly recommend registering for this one, and you can pre-submit questions so you can get your questions answered during this event. And then on Wednesday, July 8th, we have a community gather event. So this will be MDS Connection and Conversation. These community gather events are not recorded out of respect of privacy for those who are attending, but we know that not everyone knows a whole lot of MDS patients. You probably don't have too many living on your street. So this is just a way to come together as a community with people who really understand what it's like living with MDS. We have a great group, and we're always happy to add anyone else to it. So this will be Wednesday, July 8th at 5:30 p.m. Eastern Time. We'd love to see you all there. And then on Thursday, July 16th, we have What to Ask Your Physician After Diagnosis. So some really good events coming up, and we would love to see you all there at any of these. And then again, just a big thank you to everyone today for joining us, for Dr. Griffiths, for all of her time and efforts here. Truly incredible work. And if you ever have any questions, feel free to reach out to me. My email is just dalton@healthtree.org. I'm always available to members of this community, so please feel free to reach out. And I hope everyone has a wonderful rest of their day.
Happy 4th, everyone.
Happy 4th.